We're coming to the end here, and we're saving some of the best for last. The next speaker will be Dr. Gupta, and he'll be talking about options to repair L5-S1 nonunions, anterior versus posterior, both. Before he does this, I just want to share my relationship with him. I was up at UC Davis as a fourth-year resident at the Shriners Hospital, and there was a patient who had done an anterior release on the thoracic spine, had a chest tube in, and the patient had been in the hospital for about a week, and I'm calling him, he's not answering, and I was just I've never met him, I just came on the service, and I kept seeing the patients and the outcomes that he had, and I decided to do fellowship with him, and it was the best decision of my life. He is a wonderful person, the best mentor that I've had, and I get a little emotional because I'm so happy that I met you, and thank you for teaching me the right thing to do. For your new job.
Well, it was great for Alekos to come to WashU because I felt so bad. I was having a going away party at the Shriners Hospital, and Alekos came up, he goes, I came here to work with you and you're leaving. So he caught up with me at WashU and it was fabulous. We had a wonderful time. Anyway, so the topic today, options to repair the L5-S1 nonunions, anterior versus posterior versus both. Interesting topic, right? So it depends. So how do you repair a nonunion? It depends on the deformity and some of the other factors. And I made it a very clinical talk to give you some examples of how you would do cases, right? So if there's no deformity, ALIF, right? If there's a sagittal plane deformity, then you have to do an ALIF, and then you have to do a PSO because you have to realign. And then if you have a TLIF cage or whatever cage in the foramen, you can do the correction sagittally, and then you have to do an ALIF and remove that TLIF cage from the foramen to free up that nerve root. And then if there's no gross nonunion, you can do posterior only and just kind of repair the nonunion from the back. You don't have to do a formal ALIF. So that's the summary slide from the beginning. But anyway, so how do you get to that decision-making algorithm? First, I think we've talked a lot about this. Look at the standing radiograph. And if you don't have EOS, don't sweat. You can look at the patient. If you don't have EOS, you can look at their knees. Their knees are bent, you know. You don't need an EOS to tell you that. And then supine x-rays and bending x-rays just to see how flexibility is in the non-instrumented spine. And of course, the next step is CT scans. You want to look at the screws where they are, evaluate the instrumentation. Sometimes you'll miss, like there's a broken screw, and when you get in there, you're like, oh my God, it's a different problem. And look at the nonunions, define the nonunions, have as much information you can before you go to the operating room. And if the discs are ankylosed and the facets are ankylosed, you know, that has to enter into your algorithm and plan. So let's start with case examples. So it's a 68-year-old male, and he had pain, and he had S1 radicular pain. And he came with this construct. You know, this day and age, we still see patients with this kind of long fusion with just S1. And it doesn't make any sense. I mean, I think 20 years ago, we wrote a paper on biomechanics of S1 screws. It was published 20 years ago. The S1 screw, you know, I think SIG quoted a different study, but we put strain gauges in the S1 screws. And if you put an ALIF versus a distal fixation, the ALIF only decreased the stress on the S1 screw by 30%, but distal fixation by 70%. So I think adding distal fixation in a long construct is absolutely essential. So, you know, he had a previous fusion L2 to 5, and then he was having pain at 5-1, and then what did they do? They just extended him to S1, but nothing else. So he had these little bent knees. He couldn't extend because he was hurting his lumbosacral junction. And when they can't extend their hips anymore, they have to bend their knees to look forward for forward gaze. So if you look at the CT scan, he has a nonunion at L5-S1. And then you can see the halos around the S1 screws, right? Not a very complicated issue. But I get CT myelograms on some of these patients. And the reason he had S1 pain is because he had stenosis. Okay? So he not only had the L5-S1 nonunion, he had stenosis. So always watch out for things like that. Remember, you want all the information. So he has stenosis there, he had loose pedicle screws at S1, and no pelvic fixation. So these are the things that we had to fix. So what did we do? Was simple anterior fusion L5-S1, posterior fusion, revise the S1 screws, and then put iliac screws, and then he was on his merry way. So that's the first scenario. Second scenario, it's a patient who has some proximal junctional disease, right? S1 screws and leaning forward. And you can see that if you lie down, majority of the time, those junctional things are very mobile. You seldom need a VCR or any big 3-column osteotomy. So that's the first thing you can gauge from your supine X-ray. And then coronal plane is not bad at all, right? It's only the fused segment that's fused flat. So you have a nonunion, you have your proximal junctional problem, and you have a flat spine. So you have to fix the alignment, right? So, and this is the typical posture, right? They're bent knees. You don't need EOS to show you. It shows you the same thing. And then the CT scans show you loose screws. You can see, so the fellows do this, and it's a big learning experience because everybody has this imagination that these pedicles are huge, round, cylindrical things. But after they're done with the fellowship, they have a much better idea of what pedicles are really like. So you can see the halos around the screws, loose S1 screws, loose screws. So we did a posterior, we extended up higher. And some people might think it's too high, and I think that's fair. I tend to go higher just because I've had, over time, figured out that the thoracolumbar fusions are not always the most durable. And I think sometimes maybe I'm doing too many higher fusions, but that's my fault. So we did a pedicle subtraction osteotomy, and then fixed the L5-S nonunion with an A-lift instead of doing a T-lift. So if the S1 disc is not fused and you can mobilize it, I prefer to do A-lift just so I get a little bit harmonious correction there. And then if you see now his head is between the femoral head and the sacrum. Before, head was way forward, right? And that's what it looks like now, okay? So, in practical sense, Alekos knows that I take a lot of pictures because I think the pictures are valuable. So when you first start doing these cases, by the time you do this exposure and you expose everything, then you take everything out, you're already exhausted. And then you have to do the PSO. And one of the things that I can tell you is that I started doing this concept of short rods in 2000, so 25 years ago. And I think I presented it here in the first, some of these meetings. And a lot of people have adopted this because it makes so many things easier. Because once you're done with that correction, you lock it and then you can put your long rods wherever you want. And so that's what happens. You do the PSO, you correct it, and then you put the long rods around it. And that's what it looks like afterwards. So that's the flat one with the L5-S1 nonunion. So you do A-lift, and then you do the PSO to realign, right? Now it's a little different animal now. This one had a previous fusion, And there's obviously failure of instrumentation. Again, notice there's no iliac screws. And you can see the bent knees and really kyphosis at the non-union site. So this patient had a T12 to the sacrum fusion with large laminectomies. And then failure of instrumentation with non-union at 2-3 with kyphosis. And I think even if you fix the kyphosis, it would be flat. So you have to add something to fix the malalignment. But again, this is if you want to read the numbers, the PI is 67, so quite high, right? So, and look at the flat sacrum. She's maximally retroverted her sacrum and still can't stand up straight. So supine X-ray shows that there is some mobility at that level. It does come apart some, but the sacrum is still vertical. And if you look at the CT scan, there's a non-union at L5-S1. And then if you look at this one of the screws is medial. Now, if you don't study these CT scans ahead of time, you're going to put the screw right in the foramen again, or right in the nerve root, and then you'll wonder what happened. So make sure you study them. And then broken screws. So broken screws add some time to your OR because you have to drill that out and take it out and add a bigger screw. So you have to know that ahead of time too. So the coronal plane shows you the non-unions above and below where the L2-3 and 5-1. And then there's a cage in the foramen. This patient had 5-1 L5 radiculopathy with the cage. And I'm not sure if it was placed wrong or, it slipped back. I have no idea, but it needs to go. So this is a tough problem. And if I were to ask you right now, who would to remove this cage from the back? Okay, who would remove this cage from the front? Okay, yeah. So I've tried both, and I'm much better at it from the front because there's so much scar and there's so much tension on the nerve roots. I'm more likely to damage the neural elements if I try to do this from the back, although I have done it. So I think, my approach for this would be to remove the cage from the front. And then, of course, I would do a PSO to realign the lumbar spine. And then, of course, I would use multiple rods, especially around the PSO site. So that's what we did. So the first stage, we removed everything, did the PSO, and the second stage, I went back, removed, so all the alignment was already good, went and carved out the cage, took it out, make sure everything was good, and plaqued a femoral ring and bone in there. So now you can see that the sacrum is in a much better inclination. You have the lumbar spine with the right lordosis. And then, I guess I can be criticized for going higher, but I like to control the thoracic spine, especially if they're way off. So here you are. You can see that the femurs are now straight up and down, and the head is going through the femoral head to the ankle. That's sort of my gross test in a sagittal plane. And this is what she looks like clinically, and then on the clinical exam as well. All right, so the last case scenario I was going to share with you was this. This is a patient who has rods broken in the lumbar spine and the lumbosacral junction. And you can tell the sacrum is again vertical and it's flat, right? There's no lordosis here really in the lumbar spine, and a non-union. So this is what she looks like. She's young, that's why she can still stand up straight. Your muscles around your gluteus, your pelvis, kind of determine that, and the weaker you are, the more you'll bend forward. So she was able to, she's young, she's in her 40s. So what we did for her was we removed everything and did the PSO. And I did not do a formal A-lift because the 5-1 was relatively stiff. There was no gross non-union on the CT scan. So we just realigned her in the sagittal plane. This is what it looks like when you first open up, and you have to deal with the scar. And I'll give you a few tips. Remove the scar. If you don't remove the scar and you do the PSO, you're going to get buckling. And it's much better to get multiple buckles than one single one. Otherwise, you'll get problems with your quota. So this is after we remove everything, and we're doing the big decompression and the PSO preparation. Do the PSO and then put the long rods in. And then I use a lot of bone. And I use a lot of, people make fun of me because I use so much bone. And they say, well, you know, that's one way to counter the prominence of the instrumentation. You cover it with bone. So, but I think it's important. I use BMP, off-label, I guess, but still, and bone, because I think to me that's very important. So this is what it looks like. So if you look at the pre-op and then up to 2 years, you can see the head over the femoral head and the ankle lined up. That's the clinical photo. So in summary, for the evaluation part, I think standing radiographs and a clinical exam, and then supine bending radiographs, and then CT scans to look at the nonunions and the instrumentation with the screws. And then just to reiterate the sagittal plane, I think start with the pelvic incidence, build the low lumbar lordosis, and then use the arches to build up like from bottom up. And then if you don't do pelvic fixation and long construct, you'll have some trouble. Don't forget that, it's critical. So to review the summary slide I had from before, if you don't have a deformity, do an ALIF. If you have sagittal plane deformity, you have to do an ALIF and a PSO. That's the for sure way of treating an L5-S1 nonunion. If you have a cage in the foramen, I would do the PSO, realign, and then do an ALIF. But if there's no gross nonunion, and you line up the biomechanics, I think you can still get a good fusion. Thank you so much. Yes.
Thank you, Dr. Gupta. Can you hear me?
Just a fantastic talk. It's beautiful carpentry. When I do these revisions, I found, especially at S1, the haloing and screws really not being big enough.
Yeah.
Your experience in terms of requesting, you know, a lumbosacral pelvic revision set where you can get 8.5s, 9.5s, 10.5s. I've definitely haven't had those conversations ahead of time and been, you know, we didn't have anything really to fill the gap. And then I noticed in some of your revisions and constructs, just no cement. Just make a comment to that in your practice with getting fixation and abandoning that little extra kit. So.
Mm-hmm. I rarely use cement. And I don't know why, because I think that, I know that UCSF is like a thing that you guys always cement the UIV +1. I'm always worried, like if I do UIV +1, it might be the +2 that falls apart. So where to stop, where to begin? That's number one. Number two, I've seen the ones with cement, they still do a spondylolisthesis. So if it's gonna go, it's gonna go. I think it's gonna degenerate. And I know that your data shows it's better. I tried it a few times and I just was not satisfied with that. So that's number one. So I don't use cement. I use cement in like an 89-year-old that needs something done and there's no time to fix anything in terms of bone. I'll use cement with a fenestrated screw and put cement through it. But I don't cement routinely big holes and put screws in. I've done that occasionally where there's no size iliac screw that will fill the hole of the ilium because it's all bad, and then I'll put cement and then put the screw in. So very rarely I will do that. But my practice is so bad that they have a huge cadre of humongous screws that they have in the back, and then when we need them, they just bring them in. So I don't have to call for them ahead of time because every week there's a lot of revisions. So lucky or unlucky.
Munish, question, what are your thoughts about patient-specific pre-contoured rods And also maybe in that, talk a little bit about rod diameter and rod material.
Yeah, I used to love quarter-inch stainless steel because the failure rates of quarter-inch stainless steels are really low. But then the companies went away from it. It was sad because they had some data saying that stainless steel is bad, infection, all that stuff. So then I still use quarter-inch titanium rods. Those actually have better fatigue than 5.5 cobalt chrome rods because of the diameter. Engineering-wise, any engineers in here, if you increase the diameter, the fatigue goes up significantly. But now I use mostly 5.5 cobalt chrome because that's the stuff they have. And then I add from thoracolumbar junction down to below S1, an additional rod. I haven't done the 4 iliac screws that you guys are doing, and I haven't done S2AI screws very much. I remember doing an S2AI screw about 15 years ago because there was nothing else left, and I just went from the sacrum into the ilium, and I realized afterwards that it's a real thing. But I've traditionally used iliac screws forever, and I haven't had the same problems. Maybe I'm ignorant, but I haven't routinely used 4 screws, and I think the only time I really use them is if in a trauma situation where this is lumbopelvic dissociation, I use 4 screws in the ilium or sacrum ilium, or like a big time revision. But routinely, if all my constructs are basically 2 iliac screws. Yeah. And then the 5.5 rod. Yeah, go ahead, Steve.
I love seeing your talks, so thanks for sharing. And just can you go over roughly when you think you should do the front first versus doing the front back, front last? So.
Right. So I think if you want correction in the sagittal plane, then you should do the front first. If you don't need correction and you're doing it just for fusion or removing that cage that's a problem, you're getting all your alignment already, then do the front after that. To me, it's that simple. Yeah.
Again, great talks, and you have such beautiful pictures, right? Just like from earlier, from yesterday. Slightly off the topic of the title of your talk, but can you talk about when you expose?
Yeah.
Do you use like controlled hypotension? Do you use TXA? Because in your photos, what's beautiful about it, they're bloodless at that point in time.
Yeah.
I know you clean off the bone and everything, but can you talk about how you prep the spine before you start doing all the work?
So, Alekos can talk about this. All my fellows are allergic to operate on dirty spines. Because I tell them, are you gonna eat dinner on a dirty plate? So they have to thoroughly clean the spine. All the soft tissue has to be removed and all the landmarks have to be exposed because it takes a little bit of time. Because you remember, we use freehand technique with surface anatomy. So if you can't see the anatomy, you're gonna make more mistakes and it's much harder. So it's from day one, they learned that. Second, the bleeding. I use TXA and meticulous hemostasis as we go around. But these pictures are a little bit fake because we wash the wound out, we put the lap, we dry it up, we take the lap off and take a picture. So, because if it's bloody, nobody's gonna be able to see it. So that's why it looks so good. But the pictures are worth taking. And this was a tip that was given to me by Art Steffi, the Steffi screw guy. He goes, if you're gonna give talks, you can say words, but they don't mean anything unless you have pictures. And x-rays don't mean as much as real pictures. So that's why I take pictures, and I got tons of them. And my secretary has PowerPoints in every case I've ever done with pictures.
Last question.
Yes.
So you brought up the S1, stopping at S1 has very historic data showing that it's not adequate, but it continues to happen.
Yes.
And I think that's an area for our field that we need to do a better job of teaching how to do pelvic fixation. I think the pelvis anatomy is very complicated, and the orthopedic surgeons get it with trauma. The The neurosurgeons, I don't think, get much pelvic anatomy at all. And I think that it's where we should focus a lot more attention to prevent a lot of these issues for the spine world of S2AI screws, the anatomy around that, how to expose the PSIS. And I just think that it's more of a comment than a question, but it continues to happen because I think there's a lack of training around how to do it correctly.
But I think things are changing. You know, I remember when I first went to the Orient, nobody was putting any kind of pelvic fixation. It was only S1. And then we started giving talks in China, Thailand, Asia, everywhere. And then they said, oh, wow, this is a good idea. So so things have changed. And part of it was the companies weren't giving them iliac screws or S2AI screws. So it was availability and also knowing. So things have changed. And ortho neuro, I think there's no difference anymore. I really think that we're all the same. And it's just a matter of training.
I agree. Wonderful. Thank you.